Hello friends, today we are going to discuss about the ECCO therapy. So the extracorporeal system is an approach in which oxygen is added and the carbon dioxide is removed from the blood that has been pumped from the patient through device functioning as an artificial lung, typically referred to as membrane lung or oxygenator. The International Consensus Statement clarified the nomenclature for extracorporeal support as follows. The ECLS is the overreaching term to describe gas gas exchange techniques that take place extracorporeal. So the ECLS comprise the extracorporeal membrane oxygenation, which provides both full oxygenation and CO2 removal and extracorporeal CO2 removal. So extra ECOR system is differ from the traditional ECMO setup in several ways. ECOR is the term used to define subset of the ECLS in which lower extracorporeal blood flow rate, that is 200 to 150 ml per minute, are used to remove CO2. Since blood flow rate needed to reduce the hypercapnia are much lower than the required to achieve adequate oxygenation in hypoxemic patients. In contrast, ECMO describes the ECLS at blood flow rate sufficiently high, typically more than 2.5 liter per minute, to provide meaningful percentage of patient's O2 requirement. Now about physiological rationale. Because of differences between O2 and CO2 with respect to the shape of their dissociation curve, gas diffusivity, and most importantly, gas carrying capacity of the blood, the volume of blood that has to be directed through artificial lung to provide adequate oxygenation versus adequate removal of the CO2 varies substantially. 1 liter of the blood with partial pressure of arterial CO2 of 40 mmHg contains 500 ml of CO2. Thus, theoretically, maximal efficient ECLS circuit at a blood flow rate of 1 liter per minute could easily remove average patient's full CO2 production, that is 250 to 300 ml per minute. This represents the physiological rationale underlying the use of ECOR. By removing some or all of the patient's CO2 production, less CO2 must be removed via patient's lung. Thus, ECOR can be used to decrease intensity of ventilation, thereby minimizing ventilator-induced lung injury and by decreasing work of breathing, even when CO2 removed is less than the full CO2 production. Conversely, the same 1 liter per minute of the blood flow rate only add 40 ml per minute of oxygenation, substantially less than the metabolic O2 consumption of 200 ml per minute. Thus would be insufficient to provide entire metabolic oxygen requirements. Now, type of ECOR machine, material and configuration. Historically, arteriovenous pumpless devices were used which drive the blood flow across the extracting membrane using patient's native AV blood pressure gradient. However, due to vascular complications like bleeding, ischemia, compartment syndrome, pseudoaneurysm, the arteriovenous echo technique has faded from the clinical practice in recent years. Currently, ECOR devices are most often characterized by the use of smaller catheter than used during ECMO, ranging in caliber from 13 to 18 French and usually placed in veno-venous configuration using Seldinger technique under ultrasound and the fluoroscopic guidance. For some systems, the use of double lumen cannula inserted into central vein is preferred, enabling the blood flow of about 1 liter per minute depending on the size of the catheter. Blood flow through the ECOR device is usually driven by magnetic roller or that is continuous or peristaltic pump or by the centrifugal rotor aimed at minimizing heat and the mechanical trauma to the blood cell. The surface area of the membrane mostly composed of poly 4-methyl 1-pentene often range between zero point 0.3 to 1.8 meter square. The purge volume ranges between 140 to 250 ml. and the blood flow ranges between 0.2 to 1.5 ml per minute. When the blood flow is less than 500 ml per minute, CO2 elimination through the device will be about 20% to 40% of patient CO2 production. Depending on the size and the properties of membrane lung, the CO2 gradient for CO2 diffusion across the membrane and the patient CO2 production. Innovative approach is to increase CO2 elimination at any fixed flow rate has been developed by Zanella and colleagues. With this technique called respiratory electrodialysis, blood is regionally acidified using electrodialysis cell and the bicarbonate is exchanged with the chloride, leading to increase in PCO2 before blood enters the membrane or lung, nearly doubling the CO2 extraction. Other techniques such as addition of carbonic anhydrase to the membrane and regional acidification of extracorporeal blood by means of ion exchange resin have been developed as an approaches for extracting more CO2 as the blood passes through the membrane. ECCO can be integrated into standard continuous renal replacement therapy circuit, providing both CO2 removal and hemofiltration or dialysis in cases where there is concomitant acute kidney injury. The blood with CO2 removal is returned to the right heart for systemic distribution. So this is the pictorial representation of the type of the ECCO device. ECCO is divided into high flow ECCO device and the low flow ECCO device. So this ECCO can be combined into RRT when there is techniques like CRRT when there is concomitant kidney failure. Now, the indication of ECCO is in acute hypercapnic respiratory failure and COPD for control of hypercapnia RR, prevention of intubation, and risk for uh, and also it reduces the risk of extubation. Now, it is also used in the acute hypoxemic respiratory failure and ARDS. It offers ultra-protective mechanical ventilation to decrease ventilator-induced lung injury, less volutrauma, less barotrauma, less biotrauma, and control of hypercapnia induced by ultra-protective mechanical ventilation. Other indications are asthma, in which it helps in controlling hypercapnia, decreased tidal volume, and increased expiratory rate. Then bridge to lung transplantation. It is preventing intubation, and facilitate extubation. Now about the non-indication. Non-indications are refractory hypoxemia, that is PF ratio is less than or equal to 90 after recruitment and the proning, or other indication for ECMO. Untreated pulmonary embolism is the primary cause of respiratory failure. Pneumothorax and bronchopleural fistula as a primary cause of acute respiratory failure. Cardiogenic edema and neuromuscular disease that impairs ability to ventilate without assistance. Now, absolute contraindication to anticoagulation, severe coagulopathy, anatomic abnormalities or vascular disease, preventing correct insertion of ECCO cannula, severe liver insufficiency or fulminant hepatic failure, heparin-induced thrombocytopenia, known hypersensitivity to heparin or compound, ineligibility for lung transplantation according to standard criteria for bridge to transplantation patient and moribund state with the established multi-organ failure. About relative contraindication, acute multiple organ failure, defined as more than two organ failure assessed by SOFA score, recent major surgery in the last 2 weeks, recent or current use of medication known to increase risk of bleeding, acute myocardial infarction or acute coronary syndrome within 30 days, any legally authorized document that may restrict aggressive medical management such as do not resuscitate and do not intubate, permanent home ventilation except for sleep disorder breathing, advanced malignancy with life expectancy of less than or equal to 6 months, immunocompromised state, body mass index of more than 40, patient on chronic dialysis and sepsis and bacteremia. Now about complication. Complications are, it may be because of the full anticoagulation like bleeding, brain hemorrhage, GI bleeding and other bleeding. Patient can land up into heparin-induced thrombocytopenia. Catheter insertion site complication includes bleeding, pneumothorax, infection, inadherent arterial insertion and venous thromboembolism. Device-related complication include air embolism, clotting or failure, hemodialysis, disseminated intravascular coagulation, fibrin and coagulation factor consumption. Then therapy related complications include worsening hypoxemia during lower tidal volume ventilation, prolonged mechanical ventilation, and less access to the prone position. Thank you guys.